Hi, my name is Elizabeth Collins, and I am a hospitalist, nurse practitioner, and stroke coordinator. I am currently practicing in the U.S. territory of Guam, which is a small, somewhat remote island located just east of the Philippines and south of Japan in the Pacific Ocean. I have had the opportunity to participate in several medical mission trips with MMO, and I too am an active tribe member. In this video, I will briefly review a topic that I see in my practice in Guam that may also be encountered on short-term medical missions trips. The topic is tuberculosis. What is tuberculosis? Well, tuberculosis, often called TB, is a bacterial infection caused by the organism Mycobacterium tuberculosis. Pulmonary tuberculosis, or TB that affects the lungs, is the most common type of TB, but TB can affect other organ systems as well, such as the brain, spine, and kidneys. So why do we need to learn about TB? Well, tuberculosis, as we know, is mostly but not completely eradicated in the United States. However, in other places of the world, TB is still, unfortunately, a prevalent disease. According to the World Health Organization, TB remains in the top 10 leading causes of death worldwide. And in fact, a quarter of the world's population have been infected with TB in their lifetime. In 2019, approximately 10 million people were actually ill with TB, and 1.4 million people died from TB. TB is prevalent in places where MMO serves, such as Latin America, Africa, and Asia, but TB is both curable and preventable. This year, I had the opportunity to travel with MMO to Peru, and while on that trip, I encountered a patient with active TB. So I would like to take a few minutes to review a brief case study that I hope will help prepare medical professionals for how to identify and manage a potential case of TB while reducing the risk of exposure on a short-term medical missions trip. A couple of disclaimers. First, I have modified some patient details in the case study to protect patient identity. Second, I do not claim to be an expert on infectious disease. The information that I will share is based off of my clinical experience in treating patients with TB, as well as the global guidelines on this topic. And I will make some of those resources available at the end of this video through a handout. So back to our patient. The patient is a 67-year-old male who presents to the clinic with a chief complaint of nausea and vomiting. In triage, his vital signs were blood pressure 124/79, heart rate 88, temperature 98.2, respiratory rate 22, and SpO2 87% on room air. Now, in short-term medical missions clinics, we typically stick to a very focused history and a focused physical exam that are centered around the primary chief complaint. So for this patient, the chief complaint was nausea and vomiting. But at first glance at his vital signs, I did see that he is mildly hypoxic with an SpO2 of 87%, and tachypnic with a respiratory rate of 22. Otherwise, his vital signs look okay. On evaluation of this patient, my first impression was that he was not in acute distress. I watched him walk up to my desk, and while he was slightly winded with some increased respiratory effort as he sat down, he was not gasping or tripoding, and he was able to answer my questions without difficulty. The review of systems for this patient was primarily focused on two systems, respiratory and GI. The patient reported a chronic, productive, and non-bloody cough, night sweats, and mild dyspnea. He denied any recent sick contacts or travel. He reported nausea and occasional vomiting over the past couple of weeks, but denied abdominal pain, diarrhea, constipation, or fevers. He stated that he is able to tolerate some oral intake and that his symptoms come and go, but that he frequently does vomit after taking his medications. The physical exam that was focused for this patient revealed that he was awake, alert, interactive, and able to ambulate independently. He did have some mildly labored breathing with exertion, tachypnea at rest, and his lungs were diminished bilaterally with some faint fine crackles. His abdomen was soft, round, and non-tender. He didn't have any jugular venous distension or lower extremity edema. So when we consider the differential diagnosis for this patient, we consider three potential categories: acute, chronic, and acute on chronic conditions. So for the purposes of this talk, we will focus on the differential diagnoses related to the respiratory system. Some potential acute causes would be things like community-acquired pneumonia, whether viral or bacterial, certainly COVID-19, aspiration pneumonia in a patient who's been vomiting, but the patient didn't have a fever or tachycardia, which are typically present with acute infections. He had no known sick contacts, and on exam, his lungs didn't sound too bad, just some mild crackles. His cough seemed more chronic in nature, so although acute infections were not entirely ruled out, they were less likely. Some potential chronic causes would include lung diseases such as COPD, emphysema, interstitial lung disease. I did have a high suspicion for a chronic lung disease after listening to his lungs. I asked the patient, though, if he had a history of any lung disease, and interestingly, he answered no through the interpreter. He also denied a history of smoking. We also want to consider potential acute on chronic causes, things like heart failure exacerbation or tuberculosis. The physical exam was not consistent with heart failure exacerbation, but the patient's report of night sweats and the chronic nature of his cough made me question the possibility of TB. So a review of the signs and symptoms of active TB: a productive cough that usually lasts more than 3 weeks, which he had, hemoptysis, which he did not have, inspirational chest pain, unintentional weight loss, fevers, chills, night sweats, loss of appetite, and fatigue. When the patient mentioned through the interpreter that he often vomits after taking his medications, I asked him what medications he takes. At first, he couldn't remember the names or why he was taking the medications, which is not uncommon. But then his wife remembered that she had his bag of medications in her purse. Ding, ding, ding. It is so helpful when medications can be reviewed, as this usually gives a clue into the patient's past medical history, even when the patient denies ever having been diagnosed with anything. The patient's large bag of medications included rifampin and INH, two of the first-line medications for tuberculosis. I then asked the patient, "Do you have tuberculosis?" To which he immediately said yes. Although this patient had been prescribed treatment for TB already, he was symptomatic, and he admitted to frequently skipping medication doses to avoid vomiting. It did seem that his nausea and vomiting were somewhat induced by large amounts of medications that he had been taking at once. So he started frequently skipping days, which then resulted in recurrent and symptomatic infection. So in the short-term clinic setting, what are some things that we can do for patients that we suspect may have TB? Well, first of all, we can treat the patient's symptoms. This patient's chief complaint was nausea and vomiting, which was exacerbated by taking large amounts of medications at once. This caused him to then skip doses of medications, which essentially led to untreated TB. A goal for this patient was to increase medication compliance by controlling his symptoms with an antiemetic, as well as providing medication education and possibly changing the dosing intervals of his medications as well. The second thing we can do is to understand the options for TB prevention. First of all, considering the patient. You can consider counseling patients on the risk factors for TB in areas where TB is prevalent. Malnutrition and alcohol and tobacco use can increase the risk of TB. Additionally, patients with HIV are 18 times more likely to develop an active infection with tuberculosis. Also, consider the risk for the staff of the clinic and the prevention methods. So TB is spread from person to person through tiny droplets that are released into the air after coughing or sneezing. In the hospital setting, we put patients with TB or patients who are being ruled out for TB in airborne isolation. So it can be somewhat intimidating to care for patients who potentially have TB in these short-term clinic settings. But understand that though contagious, TB is actually not that easily spread from person to person. Most TB transmission occurs through prolonged exposure, such as from close family or friend contacts. But nonetheless, it is important to take precautions with any patient with a symptomatic respiratory infection. So here are some tips for the prevention of spread in the clinic. Number 1, wear a mask yourself, an N95 if you have it. Number 2, have the patient wear a mask. Number 3, minimize contact. Keep the interview with the patient as brief as possible while still obtaining an adequate history and conducting an adequate exam. Number 4, minimize the patient's wait times in closed spaces. If possible, have the patient wait in open areas rather than contained spaces near other patients, keeping in mind that prolonged exposure is typically needed for actual transmission of the disease. The third thing that we can do for our patients is to understand the options for TB testing and treatment. There are several types of diagnostic tests that are approved for TB by the World Health Organization. The first is a sputum smear, which is a microscopic exam of sputum for acid-fast bacilli, or AFB. This test is commonly used in areas with high TB prevalence. However, 2 to 3 sputum samples may be needed for confirmation. In July of 2021, the World Health Organization provided an updated recommendation that rapid molecular diagnostic tests should be the initial test for TB, rather than AFB sputum smears, due to their more rapid detection of both TB and multi-drug resistant TB. However, in order for this recommendation to become a reality, there needs to be expansion of access to these tests in some areas. So the rapid molecular tests may or may not be available in the area where you are serving. The sputum culture is the gold standard test for TB diagnosis and drug-resistant testing. So, if you are concerned that a patient might have TB, but the patient has not been previously diagnosed, you can refer the patient for testing at a local health clinic. You could refer the patient to have one of the common TB tests that I mentioned, the AFB sputum smear, or the rapid PCR or NAT test, as well as a sputum culture. Be sure to rule out TB on the referral form in case the test that you ordered is not available in that region. You might also consider a referral for a chest x-ray, though you will need to educate the patient regarding where to follow up for any test results. You may also consider a referral to a local public health department or TB clinic. You can consult the host missionaries for specific site names and locations. If the patient has already been prescribed medications for TB, consider refilling the medications if needed, or educate the patient on the importance of medication adherence. Patients who have been taking medications as prescribed for TB for several weeks are typically no longer contagious. Finally, if a patient is severely ill or in any respiratory distress, consult the clinical team leader on the trip to coordinate transfer to a higher level of care for further evaluation and treatment. In summary, tuberculosis is still a prevalent disease worldwide and a topic that we should refresh periodically as we travel to various parts of the world on short-term medical mission trips. While there is certainly much more that can be learned about this topic, knowing the signs and symptoms of TB, recognizing the medications that are used for the treatment of TB, and understanding basic methods of prevention as well as referral options for testing and treatment will help you to be confident as you evaluate patients. I hope that this information was helpful to you and will be helpful to you in your future practice, and especially on medical mission trips. Thank you for your time and attention.